Vanakkam and warm greetings from Chennai. On behalf of organizing committee, we welcome you all for the 4th annual conference of Win Icon 2025 to be held in Chennai at the Residency Towers on 30th and 31st of August. This year's theme is practicing advanced nephrology with collaboration. We are expecting around 300 delegates to come over all over the country and abroad to actively participate in this session. We are going to have workshops, panel discussions, debates. We have exciting quiz program and oral and poster presentations for the postgraduates to showcase their talent. Over the 2.5 days, we are looking forward to have a good academic jam-packed program. Also in the evening, we have a cultural event so that everybody can enjoy and also have a lighter moment. And last but not the least, enjoy the cuisine provided by this place. We again welcome you all for the conference. Thank you. The main purpose of holding this conference is to showcase the talent of female nephrologists throughout the country and bring them together, social networking and bringing out the research activities and collaborate with international delegates also.
வணக்கம். வின் இந்தியா அப்படின்றது பெண் சிறுநீரக மருத்துவர்களின் கூட்டமைப்பு. அகில இந்திய அளவில் இந்த கூட்டமைப்போட 4வது வருடாந்திர மாநாடு இப்போது நடந்து கொண்டிருக்கிறது. இதில் பெண் சிறுநீரக மருத்துவர்கள் தாங்கள் செய்த ஆராய்ச்சிகளை மற்றும் இப்போது லேட்டஸ்ட்டாக இருக்கக்கூடிய முன்னேற்றங்களை அனைத்தையும் கருத்தரங்குகள் மூலம் அனைவருக்கும் தெரியப்படுத்தியிருக்கிறார்கள். இது தவிர மாணவர்கள் தாங்கள் செய்த ஆராய்ச்சிகளை இங்கு தெரியப்படுத்தி மற்ற கருத்து பகிர்வுகள் நடக்க உள்ளன. இது தவிர வினாடி வினா நிகழ்ச்சிகளும் மாணவர்களுக்காக நடக்கப்பட உள்ளது. இதனால் நிறைய கருத்து பரிமாற்றங்கள் ஏற்பட்டு சிறுநீரக நோய்கள் அதை எப்படி சரி செய்வது, இப்போ உண்டான லேட்டஸ்ட் டெவலப்மெண்ட்ஸ் என்ன இருக்குது, இதெல்லாம் வச்சு எப்படி நம்ம நோயாளிகளை குணப்படுத்த முடியும், அது தவிர இந்த நோய்களை புரிந்து கொள்ளுதல், இதை பற்றி எல்லாம் இங்கு விவாதிக்கப்படும். இதில் பெண் மருத்துவர்கள் அனைவரும் பெண் மருத்துவர்கள் பங்கு கொள்வது சிறப்பான விஷயமாகும். நான் டாக்டர் ஜெயலக்ஷ்மி, சென்னை மருத்துவக் கல்லூரியில் பேராசிரியராக இருக்கேன். இந்த வின் தமிழ்நாடு காரியதர்சியாக இருக்கிறேன்.
I am Dr. Ranjini Muthu, Organizing Secretary of Win Icon 2025. I am Senior Consultant Nephrologist at Apollo Hospital, Greens Road, Chennai. Welcome you all.
Good evening, everyone. Firstly, I want to congratulate all the dignitaries on the dais, but also in the audience. I think all of you, what you have done and what we are seeing here today is an incredible example of women coming together to address a public health priority, a growing need, and to the best of my knowledge, it's perhaps the only speciality which has a all women group and that meets regularly and that's growing from strength to strength. So let's all give a big hand for ourselves, for all of you, that is, and of course for all the pioneers who are sitting here on the dais. I don't want to name each one of them because you have heard them, they have been recognized, and it is really in their footsteps, I think, that we see a lot of the younger nephrologists here following, and I'm told that there are many more women now taking nephrology than there used to be in the past. Certainly when I was doing my MD, it was a very male-dominated field. In fact, I did pediatrics, and pediatrics was always one specialty where you had a lot of women or maybe women outnumbering men. But in many of the other specialities of medicine and surgery particularly, you saw very, very few women. But there were role models even at the time when I was doing my undergraduate and postgraduate. We had Dr. Padmavati and her sister Dr. Janaki, of course both of them who devoted their life to medicine, one a neurologist, the other a cardiologist, lived to a ripe old age. And I had the great pleasure of meeting both of them. We had Dr. Sharda Menon right here in Chennai, who started SCARF, and of course Dr. Shanta, who started and they all dedicated their lives to the field and to the organization, for the Adyar Cancer Institute, We had a radiologist who was, I'm just blanking on her name just now, who was the director of AIMS, the first and I believe the only woman director of AIMS. And then Dr. Mridula Rohatgi was the head of the pediatric surgery department. She died very tragically in a train accident, a Rajdhani train accident. I was also in that train. And we were all going from Delhi to Calcutta for the Indian Academy of Pediatrics conference, possibly somewhere in the early 90s. And there were several people who died in that. It was a derailment. And Dr. Mridula Rohatgi was one of them. It was very shocking because she was the first woman head of pediatric surgery at AIMS. So in those days there were few and far between women leaders in medicine. In fact, if you look at the Nobel Prize in medicine, there are very few women, I think hardly 10 or 12 who have received it, and that too the first one got the Nobel Prize in medicine in 1947. This was Dr. Corey, who described the Corey cycle, the glycolysis cycle in cells. And the latest one, of course, in 2023 was Dr. Katalin Karikó, who received the Nobel Prize for her work on mRNA. mRNA became famous during COVID because of the vaccines, but her work on mRNA started in the late 80s. And she worked in universities. She's Hungarian by birth, but she emigrated to the US so that she could carry out her research. But she was discriminated in the sense that she was not really encouraged. Nobody thought that there was any future in mRNA. And she also in her autobiography has described all the challenges that she went through, and many of them were related to being a woman, because she also had a male colleague working on mRNA, and while his position was secured by the university, I think it was Philadelphia at that time, but she was constantly being asked to move because she could not bring grants, and her salary was not being supported by the university. But despite all that, for 30 years she persisted in working on mRNA, and that eventually led to a vaccine during a pandemic which nobody expected. A vaccine in a record period of time, within a matter of under 12 months. We had not one but multiple vaccines. Of course, the 2 mRNA vaccines were used very widely across most of the high-income countries. And in the rest of the world, including India, we had other vaccines like the adenovirus vector vaccines and the killed inactivated vaccine and the other protein subunit vaccines. But so the lessons from Katalin Karikó's work really show that sometimes it can be very, very hard, your life, and you have to be very committed to that particular area and believe in it. It has to be your passion for you to continue, but you never know when the reward will come. And I'm sure she did not, in all these years that she worked on it, did not expect that her work would, in one day during a pandemic, save millions of lives, or that she would receive a Nobel Prize. She did it because she believed that there was scientifically that it was possible to use mRNA to deliver not just vaccines, but any antigen that you want to deliver. And today mRNA platform is being used to develop many drugs, vaccines for other diseases, as well as monoclonal antibodies that we can use. So sometimes a career in research need not be rewarding always, but you always get small rewards and small satisfaction when you do research. So I was very happy to hear about the registry that you are running. I think registries can give a lot of information. They're very, very important. I know when I was DG ICMR that we were supporting several registries for stroke, for myocardial infarction, for psychiatric conditions, because what happens in busy hospitals, particularly in government but also in private hospitals, is that enough attention is not paid to the maintenance of records. And the big difference, I think, between countries like us and say that very highly developed countries, particularly if you look at the Scandinavian countries, the medical records are so complete, the birth and death registries are so complete that you have all of the data that you need to do analytics. And from year to year, you can look at the changes that are happening in the disease burden, in the causes of death, in what's happening to people's health. You can keep a close tab on it, and therefore the policy also can be modified and altered as per the current needs. Now, when I was in ICMR, we discovered that we did not have a disease burden, estimation of disease burden in the country state by state. So in 2017, we released, in collaboration with Global Burden of Disease at the University of Washington in Seattle. As you know, the IHME has been doing the GBD work now for over 20 years. A very, very valuable work. A lot of it is based on modeling where there's no data. So we partnered with them and the Public Health Foundation of India and released, the Vice President of India at that time released a report which showed state by state the disease burden. So for the first time it became very obvious that the southern states in India had already undergone an epidemiological transition way back in the early 90s, and that the leading causes of death were non-communicable diseases. Because when you take India as a whole, you take an average, it really does not represent the population. Because such a huge population, 1.4 billion people, we are almost like the whole of Europe, and every state in India is bigger than many countries in Europe. So having one statistic, and particularly we know that developmentally also our states are very varied, the health services, the other parameters, socio-economic development, literacy, everything is different. So this state level disease burden showed that in the northern states also you had Punjab, Himachal, Gujarat, some of the more developed states, they had a more NCD prevalence, 60-65%, whereas if you looked at Bihar, UP, Madhya Pradesh, Odisha, still there the burden was because of infectious diseases and maternal and child health conditions. So since then this disease burden has been updated periodically. The ICMR keeps on updating. But the point is really that without understanding the disease burden, the prevalence, the trend of any particular risk factor or disease, so we have to know both the diseases, which are the endpoints, but also the risk factors. How are the risk factors changing? And today, if you look at risk factors in India, they're very different from what they were 25, 30 years ago. At that time, we said undernutrition, poor sanitation, and unsafe drinking water. These were the top risk factors. And so our disease burden also reflected that. Today, if you look at those have all come down. They have not disappeared entirely. Still, in many parts, safe drinking water, sanitation, and malnutrition persist. But what we have seen is an increase, tremendous increase in other risk factors, which are both environmental, but also behavioral. So in the environmental risk factors, we see that air pollution is today the number one risk factor for health. This includes indoor and outdoor air pollution. If you add up both, it becomes number one. And people don't recognize what a big impact it's having on our health, because it's kind of invisible and you get used to it and it's there all the time, and we're very satisfied when it comes down a little bit. There's a rain and then the AQI comes down. So we are all happy that, but it's temporary. But if you look at the WHO cutoff for PM 2.5, which is 5 micrograms per cubic millimeter or 15 micrograms per cubic millimeter average per annum, the Indian cutoff is at 40. So the national air quality standards already set our cutoff a little bit higher, and yet most cities in India do not meet those standards for most parts of the year. The average AQI in India is around 55, and if you look at North India today, which is post-monsoon, has the best air quality, the average is around anywhere between 60 and 80. And if you look at the annual average, it will be closer to 100. Even cities like Mumbai and Chennai, which are on the coast, where we get a lot of sea breeze, the AQI has been progressively worsening over the last few years. Now, it's not just linked to respiratory disease, as most people think. It's linked to asthma and lung disease. Yes, it is, but it's also very much responsible, I believe, for the increase in diabetes, in cardiovascular disease, in general inflammatory and metabolic diseases, in brain diseases, degenerative diseases, and it also unfortunately has a very bad impact on child growth, brain growth, so the cognitive development of children. And of course all of these risk factors are always worse in the poorer socioeconomic groups because they don't have the means to improve their own air quality like some of us can put air purifiers in our homes. Not everybody can do that. Indoor air pollution is a very big problem, and I say this because this is a room full of women and very knowledgeable women. But the fact is, and many people don't know, that household air pollution because of biomass burning still contributes over 40% to the overall air pollution in India, and particularly in the central and above the central and northern India. So if you look at the sub-Himalayan plain, Indo-Gangetic plain, which stretches all the way from Rajasthan in the west to Orissa, Bengal in the east, and also Nepal, Bangladesh, we see that air quality there, a lot of it is contributed through biomass burning. And the simple solution for that is to provide clean cooking fuel to women. So this is an issue actually which, and of course every household in India today has an LPG connection because of the Ujjwala, Prime Minister's Ujjwala scheme. Was a huge step forward for health, for gender equity, and to address outdoor air pollution. So it's also energy access, right? So a lot of women in Asia and Africa still depend on biomass for cooking or heating. And so energy access for the poorest communities is an issue that one will have to deal with in the face of climate change. So we have to look for solutions which can have both a positive effect on the environment and on health. There are many areas like this where you could look at trade-offs and you could look at synergies. I believe that this is one of them, improving access to clean cooking fuel for women. It will result in health impacts, I think, which can be seen very quickly, including on all of the metabolic diseases that all of us are seeing. I'm sure all of you see in your day-to-day practice the impact of increased diabetes and hypertension on the kidney disease, and that's when the patient comes to you. So we were just talking a little bit earlier about prevention versus management. And as doctors, we are trained to treat people who come to us sick. I think very little of our medical education is focused on prevention or health promotion. At least I didn't pay much attention. I wasn't, but maybe it's changed now. But I believe that our medical curriculums don't have enough. Our practical experience doesn't have. When we do our internship, how much do we know about, are we taught about prevention, or how much do we actually learn? And our health outlays, if you look at the outlay, the budget for health, how much of it goes to prevention? It is maybe 10 or 15% that's going to preventive health care. Primary health care, when it was conceived by the board committee, was very comprehensive, and even today it continues to be. The overall, when you talk about comprehensive primary health care, it is prevention, it is promotion of health. Of course, when it's management of diseases, it also includes rehabilitation and palliation. So that's what comprehensive primary health care is supposed to provide. All of the needs to keep you healthy, to keep the community healthy, to keep individuals healthy. So that is what public health really is about. And as doctors, I think we have to invest more of our time, energy, advocacy, communications on disease prevention, because otherwise I think the end result of not paying attention to that is more ill health and more burden on the health system. Can you imagine the number of the dialysis centers we have today are not sufficient for the number of patients who need it. It's also painful, very costly. We were talking about the amount of water that is needed for dialysis, the amount of plastics that are generated. So it's a huge issue also when you look at sustainability and environmental health. We're actually generating a lot of that. Similarly, when you come to heart attacks, you come to stroke, you come to any of the complications, it is hugely expensive for the family, for the individual, and for the government. And at the same time, it impacts your quality of life. Our life expectancy today is 72. Okay, it's gone from 34 at independence to 72 today. That's something we can be very proud of. But how much is our healthy life expectancy? There we are not doing so well. So our healthy life expectancy is about 60. It's about 10 years less, 10 to 12 years less than our life. What does that mean? It means that the majority of us spend the last 10 years of our life in very poor health with multiple comorbidities. And so I think when we talk about life expectancy, we should really investigate healthy life expectancy and how we can make that better. There are many, many papers written about how you spend the most amount on health in the last 6 months of your life because of all the complications that one has. Now, as Indians are going to live longer, and we want people to have a longer life expectancy for sure, but we want them to have a healthy life expectancy, not just live, but also have a good quality of life. We are going to see increasing numbers of people with degenerative diseases or all these metabolic. It's normal that with aging you get more cancer, you get more of these types of diseases, especially the neurodegenerative diseases. So we also have to prepare ourselves for, and there's a lot of debate. If you see in the newspapers today, you'll see a lot of debate on our population and whether we should be stabilizing or not. Right now, we have a demographic dividend. We have a very young population compared to most parts of the developed world. So we have a huge advantage, but that advantage will last for the next 20 to 30 years. And after that, we will also then slip into a graph where the elderly the percentage would keep increasing. I think today over 60, something like 12%. It's going to be 20% by 2035 or so, and by 2050 it's going to be well above that. So we need to prepare for that, along with urbanization and all the other changes which are happening in the society. So I think the whole idea of research is extremely important, and this group can do a lot because you're still a manageable size and you're very committed from what I can see. You've already initiated this registry. I think just fine-tuning that. I have come across a few other groups like this in India which are small, like there's a group that does ICU, critical care research in ICUs. And essentially what you need to do is have that discipline of making, recording the information in a very systematic way. And this is how in the US I've seen amazing research coming out of people just collaborating. What you need is a group of people to maybe sit down, think together, what is it that we want to capture, what are the key elements, and you learn as you do. We might have missed a few things. Of course, if you can add lab investigations, genetic profiling results, etc., that adds value, CT scans, and today with the kind of digital technology we have, it's very, very easy to capture and upload all these. Once you organize yourselves into a format, which can capture it. And then one can actually open up this type of data set to the younger group, people who are doing their MDs or DMs, who want to do thesis, or even anyone else who's interested in research. Write a protocol, access the data set, analyze it, and publish a paper. Today research a lot of it is interdisciplinary, so one would need to include people with statistical expertise in your study. There are also large data sets today which are available, which sit in different departments, sometimes without being fully used. The National Family Health Survey is a very good example of a data set which has been made available to researchers for secondary research. You can access that data set and use it. We used it last year to look at the impact of climate change on the health of women and children in India. This is again a topic which we will all have to deal with in the years to come. With increasing heat, we can expect the kidney diseases to go up even more because we know one of the risk factors is, chronic exposure to heat, perhaps without drinking enough water or staying hydrated. And there are many women in occupations which are highly at risk. And personally, I have spoken to salt pan workers, I have spoken to fishermen, I have spoken to women in factories, in many such occupations where they don't have good facilities for toilet, to take a break, to have access to drinking water, particularly cool drinking water in the summer months. Forget about air conditioning and all that, but not even shade under which they can rest. So there are a lot of, health is very much linked, I think, to many of these societal issues. We know that there are social and economic determinants of health which are outside our health system. They're way outside what hospitals think about or do. And so these social and economic determinants of health they keep on changing also. And so we need to keep investigating that. So registries will tell us, if you start seeing some signal saying particular group of people seem to have a higher risk of X, then you can start asking the question,